Hey Karen, you're now a host.
Excellent. Okay, we'll give another couple of minutes if anybody else wants to join us, and then we'll get going. Okay, I think we're ready to go. What do you think, Hello?
Yes.
All right.
Uh,
All right, I'm going to introduce you and then I'm going to hand everything over for you
okay.
to take on. So, Haleh Sanaei is a doctorate psychology fellow who is trained in Iran and Switzerland. She brings a holistic approach to psychotherapy and draws both on psychodynamic and cognitive behavioral theories to support her clients who are young and experienced adults who are facing issues related to anxiety, depression, relationships, life transitions. And she's going to talk to us today about intensive short-term dynamic psychotherapy, which is an emotion-focused psychodynamic treatment that helps clients rapidly access and process emotions that they've been actively avoiding feeling. And they may be issues related to trauma, attachment injuries, unconscious conflicts. The goal is to experience deep change in a short period of time. And with that, I'm going to hand things over to you, Hello.
Okay, great. So my name is Haleh Sanaei. I have a doctorate in clinical psychology, and I came across ISTDP while I was a student in Iran, studying as a PhD student through one of my supervisors. So don't think that many people have heard of ISTDP. So I'll start with the introduction to the abbreviation. What does ISTDP stand for? So ISTDP is intensive short-term psychodynamic therapy. So it's the same as psychodynamic, but it's a more short-term form of that. And if you look at the second slide, you can see that there is a sentence by a famous philosopher called Han Fei who says that the source of our suffering is not inconsistency, but what makes us suffer is expecting consistency from circumstances that we anticipate that they are consistent. So if I were to summarize ISTDP in one sentence, that is the sentence that I would summarize it to. Means that many of us have mental representations which are static in a sense, from our past traumas or from the past people in our lives. And when we encounter those situations, we connect to this static picture and we lose the reality of what is happening in the real world, where the life itself is dynamic and is changing minute to minute. So that is where the dynamic term comes from in ISTDP. It's a dynamic therapy, which I will explain later on. If you go to the origin of ISTDP, where it came from, ISTDP was developed in Canada by Dr. Habib Davanloo, who is an Iranian Canadian trained psychoanalyst in 1960s and 1970s. And ISTDP has continued to evolve and improve through hands of more recent psychotherapists like Alan Abbas, Dr. Joel Town, Dr. John Fredrickson, Dr. Patricia Coughlin, and many others. So what happened that Dr. Davanlu, who was a surgeon, came through this and actually created ISTDP was it was actually very funny that Dr. was Davanlu was getting therapy from a therapist himself, and in the middle of the session, the therapist's phone rings. And the therapist starts answering his phone and talking with the phone. And as soon as the therapist hangs up the phone, asks Davanlu, I'm so sorry. So tell me again, how were you feeling towards your mother? And Davanlu is so furious with the therapist that instantly he says that it's better to ask me how do I feel towards you as opposed to how do I feel towards my mom. So here, the base of transference comes into play that Davon Lu taught that transference is a big part of therapy in his healing other people. So he goes and when he's dissatisfied with his therapy, he's dissatisfied with the long-term approach of traditional psychoanalysis therapy and discovered an approach to treatment that could result in a greater client change in a shorter period of time. So, first of all, he found it so long. And second, he was very angry towards his therapist that he wanted that anger to be explored. So while most psychotherapists were developed by starting a theory for mental health, applying that theory in a session and testing for positive result, what Dr. Davonlu created, ISTTB, was he started reviewing thousands of hours of videotape psychotherapy sessions to learn what worked for his patterns. So ISTTP was developed from his videotape sessions in which the patients showed Dr. Davonlu what worked. ISTDP was not created by fitting patients into a pre-existing theory. So what distinguishes ISTDP from other approaches is that he started looking at the videotapes and started creating the ISTDP. So what is ISTDP in general? What do we say when we talk about ISTDP? Sorry, do you have the picture of my slide? Because I think that can you see it or not? Can you hear me, Karen?
We can see it, but we can see your whole like PowerPoint
Yeah.
software. It's not in presentation mode.
Okay. So as long as you can see the slide, you can see the slides?
We can see the slides. Yeah, we're
Okay,
good.
great. So ISTDB is an intensive in a sense which involves constant collaboration and constant moment by moment attention of here and now responses. So when I talk about moment to moment attention, when we work with CBT, because first when I started working in therapy, I started working with CBT, which is of course the base of all the approaches, which is cognitive behavioral therapy. So when you talk with the client, you case conceptualize it, and based on your case conceptualization, you start the treatment plan and you start to go through with the therapy. But what differs ISTDP from CBT is that the case conceptualization happens throughout the session, moment to moment, based on the reaction and based on what the client is manifesting. Is the client manifesting emotion? Is it a manifesting defense mechanism? Or is it manifesting anxiety? So it's a kind of a challenging approach because you have to be alert minute to minute and have to be very observant of your client to see which mode they are in. Are they in the mode of feeling? Are they in mode of defense or anxiety? So the active focus on client responses can help clients more quickly to see, understand, and change habitual patterns of responding that may cause their symptoms. In this way, ISTDP is short-term in comparison to its psychoanalytic roots, and dynamic refers to the way in which psychodynamic therapy focuses on addressing underlying core conflicts. So we believe that every emotion that an individual actually feels towards another individual, especially people who are important in their life, are conflicting emotions. So when you're angry from an important person in your life, It's not just the anger that is makes you anxious, it's the love that you also feel for that person. And when love and anger combine together, they make conflicting emotions, which is the base core of the therapy. That is why ISTDP itself was based, the roots of ISTDP comes from the attachment theory as well, which the attachment theory, the attachment that we have, the object relations that we have, who we have conflicting emotion towards. In a way, CBT is more directive, but ISTDP is non-directive approach, meaning we do not lead the therapy. It's the client who leads the therapy, and we case conceptualize moment to moment. The map is inside the client. We just put flashlight on the map, and we help the client find its path. A dynamic in which therapist is adopting moment by moment interacts with a client who is also evolving moment to moment. So you understand that transference and counter transference is happening. You change as the client changes, and you have to be aware of this counter transference as much as you are aware of the transference. You have to be able to put flashlight on your own emotions. You have to see if you have the capacity to contain the client's emotions, which I will, describe later on the slides. What does the research say about ISTDPs? ISTDP is intensive transdiagnostic psychotherapy, which evidence of durable outcome research supports effectiveness across multiple psychological conditions shown to be helpful in disorders often considered difficult to treat, including personality disorders, treatment-resistant conditions, somatic functional symptoms, and medically unexplained symptoms. If I were to talk about the core of ISTDP, I would say that the core of ISTDP is the Malin triangle. If you look at this slide, and if you look at this, when a client comes to me, I always look at this Malin triangle. Where in the Malin triangle is the client at? Does the client come to me with anxiety? If the client comes to me with anxiety, I will start regulating the anxiety. If it comes with feelings, I will try to look for the feelings. We have this version we call the SUN in DBT. We say S stands for sensation, U stands for urge, and N stands for naming the emotion. So that is what I do. If a client comes to you with a feeling and she's sad, I put everything else away and I say, okay, what are you feeling? You're sad. Where in your body do you feel this? And what is the urge for you to do? So the urge, you want to cry, cry. Where do you feel it in your body? And if it comes with anxiety, I will try to look at which channel of the anxiety this person is and try to regulate it. And if it comes with defense mechanism, which most of our clients do, I will try to clarify the defense mechanism and try to show the costs and benefits. Remember that most of the defense mechanism have been beneficial for clients, but they are not beneficial anymore. So it's very important to see that, yes, these defenses were beneficial for you at some point in your life, but they're not helping you anymore. So which Davon Liu identifies about 152 defense mechanisms, and he actually talks about 152 defense mechanism being present in a 50-minute session, which is the talent of the therapist to identify it and clarify at least some of them. This is this is the Pearson triangle, which is connected to the Malin triangle. The Pearson triangle says that how transference happens means that how the therapist and the client are interacting is actually a small sample of how this client is interacting with other individuals outside of the therapy room. So, for example, I will give you example later on to manifest and clarify this more. But the transference that is happening between the therapist and the client is actually happening with other people who are present in the client's life, like the partner, and also the past person, meaning the mother and the father. The person triangle illustrates the same emotional conflict expressed across all 3 points. Past person, for example, when the therapist invites them to explore feelings, the patient avoids the feeling. How do you feel towards, for example, your boss for talking to you in a very bad way? The patient avoids, minimizes, or changes the topics. Well, you know, it's not just me that he speaks in a bad tone. He speaks like that with everyone. He's trying to intellectualize, he's trying to minimize. So this shows that the patient now avoids emotional conversation with the partner, which is the current person, and the patient had a critical parent and learned to avoid showing emotions. So that is why transference is the core point of ISTDP, because it can give you a lot of information about the past person in this life and the current person in the life. Example of interaction, a client becomes tense, anxious, and starts joking, using a sense of humor, which is a defense mechanism to avoid feeling angry, triggered by something that the therapist just said, which resembles how they felt with their mother growing up, past person, and also shows up in conflict with the partner, which is the present person. Now, why is it useful in therapy? It deepens the insight. The patient begins to see the recycling of old patterns. Repetition compulsion. The person says, why do all my relationship, start the same and finish the same? They're repeating the same pattern. The same pattern that they repeat with the therapist, they repeat with their current person and with the past person. So if I can make a safe relationship, this time as a person who's attuned, who's empathetic, if the relationship between the therapist and the person in the room, the client in the room changes, this relationship can be generalized in other areas of the life. So the therapist and the client relationship is a small example of the relationship that he has outside of his zone area. So what is the duty of the therapist is to clarify these defenses. The therapist can point to it. Do you notice the same defense you used with your father is now happening with your partner? And it's right now here with me what is happening. As I ask you about your emotion, you try to intellectualize. Do you realize that? What has been the cost of intellectualizing? I know that it has saved you before, but is it saving you now? It supports corrective emotional experience. In the therapeutic relationship, the patient finally gets a new response, the one that is safe, attuned, non-punitive, and this allows restructuring of old patterns. Now, let's go to the anxiety channels, which are the most important thing in the ISTDP therapy. Why are the anxiety channels are very important? Because it will give you a sense to gauge the capacity of your client. Is the client fragile? Can they not bear and tolerate their emotions? Are they rigid in terms of their anxiety? So Davanlu believed that anxiety channels are 3 channels, either straighted muscle activation, smooth muscle activation, or CPD as he calls it, cognitive perceptual disruption. So when a client comes to you, you have to see which muscle is activated, and based on that, you have to apply the pressure. So that is why you ask the client minute to minute, focus on your body. What are you feeling in your body right now? Where do you feel this anxiety in your body right now? If the client says that I feel tension in the voluntary muscles, which leads to muscle pain, I feel tense all over my body. I have tremors. I have tension headaches. I feel my jaw clenching. For example, these all are voluntary muscles, which says that the anxiety is in a straighted muscle, and you can push towards the emotion, push towards seeing what this person is feeling towards the person who has made them angry, or to the fear that they are feeling, any other emotion. If the person says that I feel that I have a stomach pain, or I feel that I have heart palpitations, and I think right now I got this migraine right now. You understand that the anxiety is in the smooth muscle, which is the involuntary muscle. Here is a big stop to you. The therapist has to stop and regulate the anxiety. This shows that the patient cannot tolerate more anxiety. So we have to stop, we have to regulate, and we have to go back until the anxiety goes back to the striated muscle. And the CPD channel, which is the last channel of anxiety, is where your cognitive functions are disrupted by your anxiety. Sometimes in therapy sessions, the client says that I see you too big, or I can see you very small. Or sometimes they get tunnel visions and they get blurry visions. That is why you have to keep asking them, and you have to keep tracking their symptoms and see where the anxiety is discharged in their body. If the anxiety is in CPD, which is cognitive perceptual disruption, or in the smooth muscle, this is where you have to stop, you have to regulate, and you don't have to put pressure on the emotion. You don't have to expose. This is the stop point. You can only pressure if the anxiety is on the striated muscle, which is the voluntary muscle. And also, these activation channels actually show you how fragile or how rigid your client is, how much capacity they have, how many times they have been traumatized. It can give you a lot of information about your client. What is again very important is the role of therapeutic alliance in ISTDP. You have to remember that each client who comes to us is 1 foot in therapy and 1 foot out. So 1 foot in is that they want to get better. They say that I feel that one part of me wants to get better, but there is another part which is resistance. So Davon believed that resistance actually helped the therapy, because imagine when we talk about therapeutic alliance is when you want to learn how to swim, and for example your coach pushes you inside the swimming pool. On one hand you're angry from the coach, on the other hand he's trying to help you swim. This is exactly the same thing when it's happening in ISTDP. Is empathy in ISTDP is not just paying attention and empathizing and putting yourself in the other person's shoes, as in to say that, oh, I understand your world. I understand what you mean. Empathizing is showing their defenses to the person. For example, when you ask about their emotion and the person says that, well, I think he didn't mean it. He's trying to intellectualize, or he tries to rationalize, and you say, do you notice that you're trying to rationalize in order to escape from your emotion? This is empathizing. Because, or if the person is attacking themselves, do you notice instead of exploring your emotion towards that person, you're trying to attack yourself? So empathy is clarifying the defense mechanisms and showing the cost of defense mechanism. This is how empathy in ISTDP differs with other approaches. So therapists must distinguish 3 rapid moment-to-moment responses. As I said, the client either comes with feeling, defenses, or anxiety responses. So if it comes with feeling, you have to explore the feeling. What is the feeling? What is the name of the feeling? Is it anger? Is it grief? Is it love? Is it guilt or longing? Where in your body do you feel this? And also, what is the urge? Do you want to run away? Do you want to cry? Do you want to do something about that anger? And either comes with defenses, intellectualization, rationalization, sense of humor, joking about everything. As soon as you ask them about their feeling, they start joking around to distract themselves from the feeling, or they change the topic, or they avoid talking about their emotions, or they come with anxiety responses. Why are you so anxious? Where in your body do you feel this anxiety? Tension, sighing all the time. You see that they become short of breath and they're sighing all the time. Tightness in the stomach, they have tremors, and they say that I feel blurry, I can't think very well. Internal questions for the therapist. So the therapist has to ask, is this an emotion? Is it a defense? Or is it an anxiety? Now, why accuracy matters is mislabeling a defense as an emotion or anxiety as defense causes confusion, and confusion weakens the therapeutic alliance. That is why it's very important to clarify this. Clarity allows the therapist to keep the patient focused on emotional experiencing. Alliance must maintain focus on contacting real feelings, feeling them directly in the body, and letting them rise without inhibition. For example, many of our clients come to us because they're scared of their anger. As soon as they talk about their anger, they're scared to feel the anger inside their body. So they come and say, I'm an angry person. I act out all the time. I yell. This is an actually angry person because that person actually fears to feel the anger in the body. It doesn't have the capacity to feel the anger in the body. That is why it throws it out. Or some people don't have the capacity to feel the anger in the body, so they suppress it. Both of them are wrong, either suppression or acting out. What the therapist does is allowing them to feel the anger in a very safe environment, to feel it in the body. Name it, feel it in the body, and talk about the urge. If you look at the layers of feeling in ISTDP, if you consider this as, onion layers, as I said, ISTDP comes from an attachment theory. It says that most of our emotions are conflicting emotions. So when in attachment, when there was love and your love was not answered, for example, there was a big hurt from your love not being your mother not being responsive to your love, and which caused you a pain and grief. As a result, you become angry. As a result, a guilt feeling comes up. So these all happen unconsciously, and you build defense mechanism that never again I want to get close to anybody. So this is where intimacy issues happen. People who have problem with intimacy issue. So Dallin Liu is an intensive emotion-focused psychodynamic therapy with an explicit focus on handling resistance in treatment. If we look at the core, they are healthy feelings on the surface. There are defenses trying to avoid those feelings. Love is the deepest layer. This is the core feeling we have toward important people. Love, attachment, need for closeness, longing. Why is it buried? Because relationships are complex. And when love is blocked or hurt, painful emotions get stirred up. Pain and grief. When someone we love hurts us, leaves us, or disappoints us, we feel hurt, sad, lonely, grief, loss, and the pain sits right on the top of the love. Anger. If the pain is not expressed or resolved, anger forms. How could you do that to me? Why didn't you protect me? Or you hurt me and I'm angry. This anger is healthy, but many people fear it. They fear to be angry from the person they love because they want to protect their relationship, so they bury it. And as a result, there is guilt about the rage. When someone we love is also the person who makes us angry, we feel guilty. I shouldn't feel this way. It's wrong to be angry. I feel bad for having rage towards someone I love. This guilt blocks the anger. And then because you have to remember that most of these defense mechanisms are created when you're at age 3 to 6, because the child doesn't have the capacity to bear it. That is why it makes these defenses. Doesn't have the capacity to say that the person whom I love, I'm also angry at. So it comes up with defenses against closeness, which is the outer layer of what we see, right? Pulling away from people we love. As soon as they get into a relationship and they get intimate, they want to run away. They avoid intimacy. They get themselves numb. They change the subject as soon as they want to talk about something intimate or private. They are people pleasers, or they're pretending not to care about things, or being anxious all the time. Um, there is a small example of a dialogue that a person, a client, and a therapist can have in the therapy session that I brought you here, which actually shows what empathy means in the therapy session. You look a bit anxious right now. Are you aware of that? No. This shows lack of observing ego. The ego is not observing. The client is not aware that he's anxious. Have you noticed that your legs are trembling? Yes. That trembling is one sign of anxiety. Are you also aware of the tension in your shoulders? Well, they're always like this. So the client is ignoring or minimizing anxiety is still ego syntonic, doesn't see it as anxiety. It says that this is me, this is who I am. You notice the tension, but you tend to treat it as something normal. In other words, anxiety feels egosyntonic. The patient is not aware of it. I don't know if it's natural or not, but I'm always like this. Being this tense most of the time isn't actually natural, is what the clinician says. It shows that your body is signaling anxiety quite often. Okay, but I have something more important I want to talk about. It's interesting. The patient is trying to change the subject and is not paying attention to the anxiety. He says, I have something more important. He's trying to ignore the anxiety. And he's not aware of it. I notice you want to move away from the anxiety. Do you see that? Yes, because there are other things I want to discuss. If we shift to other topics right now, we would again be ignoring your anxiety, and that wouldn't help you. Clarifying the therapeutic stance. Do you see how therapeutic alliance is here? What kind of clinician would I be if I help you avoid the very feelings your body is showing right now? Not a good one, the patient says. Exactly. And when you ignore your anxiety like this and try to move to other topics, do you find it helps you understand yourself better, or does it get in the way? I don't find it helpful, but it is something I do. The person identifies with this defense. Is it something you would like to continue doing, ignoring your anxiety? No, the thing is, I never pay attention to it. So here you talk about the cost of not paying attention to the anxiety. And that's precisely why we need to pay attention to it here together. You're here to get help with your anxiety, and for that to happen, both of us have to focus on it at this moment. If we ignore your anxiety right now and right here, we won't get to the root of what is troubling you, and I won't be helpful. I will be another unhelpful person in your life. Davon Liu actually talks about defense mechanism and talks about tactical defense mechanism, characteristic defense mechanism, repression-based defenses, and primitive defenses. So remember, defenses and anxiety channels are two clues that tells you how traumatized or how fragile your client is, and gives you the clue how much you can pressure and how much you can go forward. If character defense and tactical defense are present at the same time, our priority is the tactical defense. Tactical defenses are defenses which doesn't allow the client to get intimate with the therapist, intimate in a sense to talk about their feeling. What are tactical defenses? Vagueness. The client is talking, but you can't make sense of what the client is saying to you. Intellectualization. The client is talking to you, but he's talking like he's saying a news. Like 250 people were died in a plane crash. So why is there no emotion? The person is talking about something sad, but there is no emotion in what he's saying. Sarcasm, right? Or making a sense of humor, joking about things as soon as we talk about something important. Avoiding eye contact or body posture. These are all tactical defenses, and if they are present in the session, these are our top priority that we have to pay attention to. Character defenses are like self-attack, self-criticism, externalization, blaming others for things that they were responsible, passivity and helplessness. The client comes to you and is passive in the session, is not talking, and this is where you go back and you say that why is the therapist trying more than the client? The client is sitting there passively. You help me heal without even saying anything. So this is another defense mechanism that we need to pay attention to. How it differs from other therapies like CBT, CBT usually talks about cognition and restructuring, looking at your cognitive errors and replacing them. ISTDP mostly looks at the emotions. What are you feeling right now? The emotions that have been suppressed for so many years, and they have been suppressed in your body. Mechanism of change. In ISTDP, change occurs through unlocking of the unconscious and experiencing warded off emotions in the session, where in CBT, change occurs through modifying distorted thinking, exposure, and behavioral activation. Relationship with symptoms. ISTDP symptoms are caused by anxiety generated from avoided emotions, whereas in CBT, symptoms are maintained by maladaptive thoughts and behaviors. In ISTDP, the clinician is very active. It's confronting, pressuring, and supporting by challenging the defenses of the client moment to moment, whereas in CBT, it's more directive but collaborative and is teaching skills, psychoeducating, and assigning homeworks. ISTDP is moment-to-moment monitoring of defenses, anxiety, and emotions, tracking somatic anxiety patterns, pressure to feel, clarify defenses, and challenge avoidance. So I think this is the end of my slides. So Karen, I will get back to you. If you have any questions, I will be more than happy to answer.
Alrighty, that was amazing presentation, Hal. My feeling as I'm listening to this is that feels exhausting. To have to be that on point and doing that moment-to-moment observation. And I'm curious what it was about intensive short-term dynamic psychotherapy that really clicked with you. And was there a moment in your clinical practice or in your training that you said, yeah, this is something I really want to dive into?
Yes, so it's the creativity and the challenge of the case conceptualization moment to moment that you have to think based on the client's reaction. You have to come up with another case conceptualization at that moment that actually drew me to ISTDP because I found it boring to just do homeworks and just give go and do this. But more important than this, because in my career there was a long time that I was working with CBT, and I had clients who were going through grief, and when I worked with their cognition, and I said, well, this is this, and I in a way I was trying to intellectualize what they were telling me. They said, I know that what you're telling me is true and it makes a complete sense. You are rational in every way possible, but I don't know what to do with my emotion. What about my emotion? I know that this guy is not right for me. I know that everybody said that he's not, but what should I do my emotion? I have hard time coping with my emotion. Where in ISTDP, everything is about emotion. Right? So intellectualization is a way of you escaping from that emotion. So that is what clicked with me with ISTDP, that I wanted to do something for the clients and for that emotion.
Okay, that makes a lot of sense. I'm curious, when you have a client coming in to see you, how do you know whether this is going to be the right approach for them or whether, a traditional CBT model might be better?
So it depends. For example, it depends. Many people, when they come, especially if they are traumatized, or for example, let's say that they have relational trauma. In relational trauma, I gauge them by their anxiety, I gauge their defense mechanism, and I gauge their emotions, right? Some people, they have been so traumatized that when you talk about their anger, they have so much fear that they don't want to go there. They say, I know that's what you're trying to expose me, but I'm not ready to be exposed with this anger. Can we work with a different approach? Um, I have few clients like that, but majority of them usually tune in with the approach. They like it and they want to be worked on on the emotion. But what I gauged is the level of the anxiety, their defense mechanism, and as I said, are they ready to be exposed with the suppressed emotion or not? Because when a person comes to therapy, first they have to accept that they have problems. A lot of them sometimes are pressured by their significant others or some important people in their life to be in therapy. So this is very important. So many factors are considered when you work on ISTDP. Their readiness to be exposed to the suppressed emotions, how much traumatized they have been, or is it relational traumatized? Is it one-time traumatized? They have phobias, specific phobias or whatever. For example, if it's a specific phobia, I would rather do CBT than work with ISTDP. Does that make sense?
Yeah, totally makes sense. Um, I'm curious because it so much relies on somatic awareness.
Mm-hmm.
And do you sometimes have to do work with the clients to help them to develop the capacity for somatic awareness before you can start doing a dive into what do those feelings mean? Like if you've got a client
Definitely.
who's always in their head and they're not aware of what's going in their body.
Yes, with people who have obsessive compulsive disorder, it's interesting that they're always able to say that, oh, I'm angry or I'm scared. But when it comes to their body, they actually feel numb. And it's very, it's interesting for them as well. Why do I say, how do you know you're angry? What do you feel in your body that you say? They say that I don't know, it's just in my cognition. I know that I'm angry, but I don't feel it in my body. So sessions and sessions I spend on them. So I have to move very slowly with them, right? To just staying on their body, asking question repetitively until they become familiar with these bodily sensations. It doesn't mean that they are developed, they're already there, but they have been numb for many years, right? And through therapeutic alliance, through empathy, through showing the cost of their defenses, gradually they will come to these senses become tangible for them.
Okay. Are there experiential somatic activities, interventions that you use to help them actually feel their body, like things like tapping or any of the bilateral stimulation, anything like that? Or is it
No.
purely
Yes,
emotional exploration?
yes, it's purely the emotions that are stored. I actually recommend acupuncture very well because with acupuncture, there are many emotions which are stored in the body, especially with people who have been traumatized, which with acupuncture, these emotions get to be released. It helps a lot alongside ISTDP because the emotions come up, and if you have ISTDP and acupuncture alongside each other, it helps a lot. But no, it's purely by asking questions repetitively and staying on the body repetitively. That is why sometimes it can get boring for some patients, right? They have to bear, but gradually they will come to sense, even if it's a little. We stay with this little, and gradually it will increase. Gradually, you know, they come to forget the old neural pathways, and new neural pathways are built on old neural pathways because some clients are always in their head by ruminating. Whatever it happens, they ruminate it. I said, do you recognize that rumination is a way that you distract yourself from your body? In a split of a second, it happens in a split of a second that they don't realize it themselves, right? So by repetition and by asking questions, gradually, I have never seen a patient who, for example, hasn't broken that cycle. At some point, the cycle breaks and they can feel the feeling inside their body.
It's a very challenging and a little bit in your face modality, which some
Yes.
clients are going to really welcome and some clients are not. What psychoeducation do you give them to prepare them that this is the experience they're about to undergo?
So usually I don't give them psychoeducation unless um, they find it that, some of them might say that, oh, it's a bit interrogating, I feel that you're interrogating me or something. Then I would recommend some papers, like some articles for them to go and see how evidence-based it is, and just spend a session psychoeducating them on the results of how effective this therapy has been. And usually it works when you psychoeducate them and you see that, what I am doing right now is not pressuring you or not interrogating you. I'm just clarifying your defense mechanism. And you have to be careful that the tone of the clinician is very important. I always say that you can use the same content but with a different tone, and it might sound insulting. For example, can you open the window, please, as opposed to can you open the window, please? Right? So the content is the same, the tone is different. So the tone of the clinician is very important as it's clarifying the defense mechanisms here. So that the patient doesn't feel integrated. Does that make sense to you?
It does make sense, yeah. You had mentioned at one point in the presentation a client talking about, I have a part of me that wants this and I have a part of me that wants that. And I'm curious whether you have integrated any parts work into this approach, IFS or ego states, anything like that, to help them develop awareness of different aspects of their subpersonalities.
Yes, so I haven't used IFS. I am familiar with a bit of ISFS. If I were to compare IFS with ISTDP, I would say that the exile parts are our emotions, the emotions which have been suppressed for long time. And the manager is the defense mechanisms, which is very rough and cruel, and we want to get rid of it. And but both IFS and ISTDP are trying to bring authentication and integrity for the clinician, leadership of self. This is the aim of both of the IFS and ISTDP. So if I were to compare for it, the anxiety is the firefighter. The defense mechanism is the both the protector and the manager, and the suppressed feelings are the exile feelings that you need to be exposed to in order to feel better. But I think that the aim of both of them is the same, for the client to stop lying to themselves. There is a book that John Fredrickson has, The Lies That We Tell to Ourselves. All these defense mechanisms are lies that we tell to ourselves so we don't see the reality. The reality is the feeling that we really feel. Rationalization, idealization, devaluing, intellectualization. These are all the lies that we had to tell ourselves when we were little kids in order to protect the relationship that we had with our parents. Because as a child, I didn't have the capacity to bear conflicting emotions of love and anger. It helped me as a child, but is it helping me now as an adult? Showing the cost of this is empathizing with the client. It's tuning in with this, clarification of the defense mechanisms and also showing the cost of it. And I think IFS and ISTDP are similar in that sense.
Yeah, yeah, that makes sense. We've got maybe about 3 or 4 more minutes before we have to wrap up. So if anybody else has questions to ask, please just raise your hand and we'll let you in. It requires so much of you as a therapist, that moment-to-moment awareness. I'm curious what practices you do for self-care so that you're not getting burnt out as you're being exposed to these really intense emotional experiences of your clients.
Yes, so as Davon Lu calls it, ISTDP is a true psychology person. means transference and countertransference. Some countertransference are induced by the patient, which you clarify it at then and right there and then, and you have to be aware of your own bodily sensations as you tell the client what do you feel in your body. At the same time, I'm looking at myself and I say, what do I feel in my body? For example, a client is going through a grief, and sometimes you can't tolerate if you don't take good self-care, you get anxious as they try to cry and get sad. And if you are aware of it, you stop pushing. You stop pushing and telling the client, okay, feel this sadness, let it out. And sometimes you don't pay eye contact because it's really hard for you to see that sadness in them. To be aware of that is very important. And the care that you have to take, first of all, is awareness that what do you feel inside. And this, for example, this doesn't scare you to push the client forward when it's you're at the core of the healing and the client is trying to feel the grief. And second, getting therapy. I myself get therapy with an ISTDP therapist, and also being in supervision also helps a lot for self-care.
Yeah, that totally makes sense.
Yeah.
There's a quote that stood out for me from John Frederickson, who describes ISTDP as involving relentless empathy. And I was curious what that means to you as a therapist.
Mhm. As I said, I think that empathy in ISTDP differs with empathy as in giving attention or putting yourself in a other person's shoes. Empathy is when you show the defense mechanisms to the patients and you show how these defense mechanisms have deteriorated their life and the costs of it, how they have made them anxious, how they have paralyzed their life, and you try to challenge them to stop using defense mechanism. This is the empathy that you're showing towards the client. This is how John Frederickson and Davon Liu describe empathy, means clarifying the defense mechanisms and staying with the client so they can explore the suppressed feelings that they have feared so long. Does that make sense?
It does, yeah. I think we're going to stop there. Does anybody else have any questions that they would like to ask? Hello.
Yeah,
I'll go.
Haleh, thank you so much. You already know I love your thinking, and thanks for the talk. I think, in my experience, we have a couple of camps, right? There are people who are often doing technical work. They're more of the technicians, and I think a lot of us, most of us, the more I talk with other clinicians, most of us are either implicitly or explicitly thinking this way, that there's a functional analysis to anxiety, that anxiety isn't just a feeling, it's a conflict. Uh, it's an unconscious choice. It's a pulling in different directions, and you're speaking to that and working with the client to help them understand that the feeling of anxiety is not your anxiety. And so in that vein, I'm curious how you work with people who come in heavily identified with emotion and conflicts as an identity. My anxiety, my OCD, as if these things are actual things that we have, which they're not. They're diagnoses of conceptual, of symptomology, right? Of
Mhm.
They're concepts. There's no such thing as anxiety. It's an experience and a process. So uh, I'm curious how you work with someone who comes into your office and, um, you know, says, I'm here to get rid of my anxiety disorder.
So when they say my anxiety, as I said, it's egosyntonic. Egosyntonic in a fact that this person feels that the anxiety belongs to them. And it's the therapist's duty to make that ego dystonic, means to know that this anxiety is not you. It's a way of diffusing the anxiety from them, right? So how to diffuse this anxiety is okay, staying with this anxiety. Let's look at this anxiety, okay? Anxiety is not attached to you. It comes and goes, right? So where do you feel it in your body right now? So if a person comes to me with anxiety, you say my anxiety because they're so fused in with their anxiety that they think that anxiety is them, right? So our job as a therapist is to diffuse this. How do we diffuse this? As soon as we look and pay attention to the anxiety in their body, their anxiety starts regulating and they get amazed. They say, what happened to my anxiety? I say, see, anxiety is not you. As soon as you pay attention, it goes away. So regulating the anxiety is a way of diffusing the anxiety and knowing that this is not my anxiety. Anxiety is because Paul, I know that anxiety is not an emotion. Many people call anxiety as an emotion, right? In ISTDP, anxiety is not an emotion. Let's look what emotion you are suppressing that this anxiety is coming up. So as soon as you regulate it, then we look at the emotion that is coming up. And as soon as we find the emotion, the anxiety is goes away. When the anxiety goes away, the person understands that they're not the anxiety, and this is not my anxiety. The anxiety comes and goes. Does that make sense to you or not?
Of course, you already know what I'm thinking. That
Yes,
it
yes.
makes perfect sense, and I think it's an important message for us all to hear, because something, and it's just part of the therapy. It's all grist for the mill, but something that does come up in my practice often is not just an identification with my anxiety, but having a long list of clinical experiences of clinicians telling them that this is your anxiety disorder, which adds an extra layer, and it does add time onto to the time to process and get to this point of coming back to actually there's more to me than I know, that I can relate to myself in a way that changes how I feel, and that this idea that I have this disorder or that I am the anxiety. It just takes a bit more time to work through. But no, I appreciate what you're saying, and that's great. Thank you. Actually, if you well, I'll see if anyone else has a question. If no one else does, I'd love it if you talked more about confusion, or we
Oh,
can.
we've got like 1 minute left. Um, this would be an amazing topic to come back and circle back on, I think, because there's just so much richness here for us to explore. So yeah, I think we kind of have to, for people that have clients at 2 o'clock, be aware that this is it. Halal, you did an amazing job. Um,
Yeah, thank you
I
so
am
much for
very
inviting me.
intrigued in this approach. It feels like there's so much intense learning that needs to be done.
Yes.
If somebody wanted to learn more, where would you suggest that they start?
Um, there is a book which is called Recreating Yourself by John Fredrickson, or The Lies That We Tell Ourselves, which I always introduce to my clients. It's written by John Fredrickson. I would recommend this. This is an easier book, The Lies That We Tell Ourselves by John Fredrickson. If you start reading that book, it will give you a sense of what ISTDP is.
Amazing. All right, awesome. Thank you.
You're
All
so
right.
welcome. Thank you so much, Karen, and thank
Thank
you,
you for
everyone.
everybody for joining us.
Thank you. Bye.
Mm. Okay, we're done.